Thank you very much. I have to say this is probably one of the most enjoyable programs I have ever worked with. And so it's been a true pleasure to really be able to be part of what I think is a truly amazing and very integrative service. And really it serves as a model for, I think, how clinics should really be set up. And so I really appreciate the opportunity to actually be able to work with this group. So our first talk today is going to be by Dr. Santhosh Upadhyaya. Is that close? Okay. I really feel bad, I have to tell you. So I've been working with Santhosh for the last 3 years. So Santhosh he's in our last year of our fellowship program in our pediatric hematology oncology. And I had to actually come up to him and say, honestly, I don't know how to pronounce your last name. So I feel bad after all this time, but he's lovingly referred to by almost all of us as Santhosh. But he really has been a true pleasure to work with. And he's going to go on and do absolute great things. And he has a great opportunity. He's going to be joining St. Jude's next year. So today he's going to be talking about work with DNA repair and its role in Ataxia Telangiectasia. Sorry, I always have trouble with that one. All right.
Thanks, David, for those kind words. And you actually did a very good job of saying my last name, so I really congratulate you on your brave attempt. So as David said, I'm one of the third-year pediatric hematology oncology fellows here at the University of Michigan. And I'll kick off the morning session with a talk on the role of DNA repair in causing immunodeficiency and malignancy in patients with Ataxia Telangiectasia. I have no financial disclosure to make. I'm going to begin with a case description, one of the patients that was seen in our hospital. This is an 8-year-old boy who presented with fever, enlarged neck lymph nodes, and hepatosplenomegaly. On review of history, it was found that he had a history of unsteadiness with prominent dilated blood vessels noted in his eyes and on the skin by his parents. He underwent a neck lymph node biopsy and also subsequently a bone marrow biopsy, which was positive for Hodgkin's lymphoma, thereby staging him as having stage 4 disease. So given this combination of unsteadiness, a telangiectatic rash, and now presenting with the malignancy, we were highly suspicious of him having Ataxia telangiectasia. So we ran an alpha fetoprotein, which came back as elevated. Subsequently, we also did a chromosomal fragility test, which was also positive. And given all these findings, it was kind of most consistent with the diagnosis of Ataxia telangiectasia. So Ataxia telangiectasia, or AT for short, is an autosomal recessive neurodegenerative disorder. It's characterized by progressive cerebellar ataxia, oculocutaneous telangiectasias, and variable degree of immunodeficiency. And as these two pictures show, these patients usually have dilated blood vessels called telangiectasias in their eyes and on the skin, and also in their mucosal regions. These patients usually have an elevated alpha fetoprotein. In fact, 95% of the patients have this, and this forms a useful biomarker for the disease and a useful screening test. They do have an increased predisposition to cancer, and also they have radiosensitivity and sterility, which are like the accompanying features in most patients who suffer from Ataxia telangiectasia. The basic underlying molecular mechanism is a biallelic inactivation of the Ataxia telangiectasia mutated protein kinase. So for short, it is called ATM. And the gene for this protein is located on the chromosome 11q. It's kind of now well known that in patients with AT, there is a defective response to a DNA double-strand break. And it is thought that this happens because ATM plays a vital role in the response to that double-strand break, which is the DNA damage response. It has another vital role in the cell cycle checkpoint control mechanisms, which kind of screen out the bad DNA or the damaged DNA. It also plays a role in apoptosis, oxidative stress, and mitochondrial metabolism. So what is the response of a cell to DNA damage? In response to various stimuli, there happens double-stranded breaks in most of the cells on a routine basis. So when this happens, this break is kind of detected or sensed by a protein complex called as the MRE11, which further activates the ATM protein at the site of the break. This is followed by post-translational modification of the ATM, including autophosphorylation, which in effect activates effectors, the net result of which is either cell survival through DNA repair, cell cycle checkpoint mechanisms, or modulation of metabolic pathways. Or if this does not happen, the next thing that could happen is cell death, which there is the activation of the apoptotic pathways. And hence you will see that depending upon what the response is, ATM plays a very crucial role in the response to double-strand breaks and other DNA damage that happens. It is also well known and kind of an established fact now that AT patients have an increased predisposition to cancer, and predominantly these patients have lymphoid malignancies, with leukemia and lymphoma forming about 85% of the tumors. Now, one of the possible mechanisms for this is thought as the ATM plays a vital role in the DNA damage response that happens due to a double-strand breaks, as I pointed out earlier, during a process called as VDJ recombination. So VDJ recombination is a step which is required for for the formation of antigen receptor genes during T and B cell development. So in effect, what this does is it defines the properties of the receptors, of the various receptors. So during a double-strand breakage between the, all right, good to get the pointer, okay, here. During the double-strand breakage that happens during the recombination of the variable regions, the diversity segments and the joining segments, this double-strand break has to be followed by repair, okay, so that the recombination happens in a proper way. So if the ATM is not available, this recombination may be hampered, and in effect, what it is thought that it may promote translocations, which may result in oncogenesis. So explaining one of the mechanisms which may predispose to cancer. The other very important step which may explain the role of ATM in cancer predisposition is the cell cycle checkpoint mechanisms. So the cell cycle checkpoint mechanisms are important in various phases of the cell cycle, just to make sure that the damaged DNA is either repaired or it is kind of does not make it into the next step, because then that would promote DNA instability. So there are two steps, or there are two places where the ATM may play a role in the cell cycle checkpoint mechanisms. One of them is between the G1 to the S phase, where P53 also plays an important role by repairing the DNA damage. And it is thought that ATM is required for the stabilization of P53, in the absence of which you have accumulated DNA damage and it does not get repaired. The other failure that happens is between the step G2 to mitotic phase, where there is a failure of activation of the checkpoint kinases 1 and 2, with the resultant defective cell checkpoint mechanism. And again, the net effect is the same. You have accumulated DNA damage, which promotes genetic instability and hence increases the predisposition to cancer. The malignancies in AT are, the risk of malignancies is about 10% with each passing decade. So by about 40 years of age, the cumulative incidence is about 40%. Generally, as I said, lymphoid malignancies predominate. And among the lymphomas, the NHLs are the ones which are more common. And these are generally high grade and also predominantly B type. A particular type of leukemia called as the T-cell pro-lymphocytic leukemia is also seen in increased incidence in these patients. But these generally occurs in adults with a median age of about 25 years. And one of the interesting features is that it has been noted that these may evolve from T-cell clones with recurrent chromosomal rearrangements involving chromosomes 7 and 14. So that may be an earlier sign of impending malignancy. About 15 to 20% of the cancers are non-lymphoid, and they're primarily carcinomas. Now, patients with Ataxia Telangiectasia not only have an increased predisposition for aggressive cancers, but there are certain other challenges in the treatment of these patients just because they have a defective DNA repair mechanisms. One of them is these patients generally have an increased resistance to standard chemotherapy. High-grade tumors increase resistance to standard chemotherapy, so that's not a good thing. And it is thought this is probably because of decreased apoptosis, which is generally required in the presence of chemotherapy. It's also thought maybe because of the chromosomal translocations, These tumors have unusually aggressive biological characteristics. The second thing, as I said, is increased radiosensitivity. All of these patients have increased radiosensitivity. So basically what it does is you're not able to provide the standard radiation dose to these patients, and hence the tumors which may be actually treatable, you're not giving the optimal treatment, and hence you cannot expect a cure. They have high mortality during the chemotherapy regimens due to infectious complications. They also have unusual toxicities which you would not expect in patients without AT, like pulmonary leak due to a low-dose RSE, late onset pulmonary failure. They might have extrapyramidal side effects because of the underlying neurodegeneration. And finally, they definitely have increased toxicity to chemotherapy drugs which require a dose reduction. Now, hence, all of these factors, when you put together, you have an aggressive tumor, you're not able to provide optimal treatment, and then you have increased toxicity. So those are the unique challenges in the treatment of these patients. Just going back to our first patient. So this was an 8-year-old boy with a history or with the diagnosis of Ataxia Telangiectasia and now with a stage 4 Hodgkin's lymphoma. We treated him with a modified chemotherapy regimen which was meant for AT patients. Some of the modifications that we did was were a lower dose of alkylating agents because these patients have an increased risk of hemorrhagic cystitis. Substituting vinblastine for vincristine to reduce the neurotoxicity. And also dose reduced the topoisomerase inhibitors to decrease the risk of mucositis. We were able to achieve disease remission in this patient. However, the joy was short-lived. He relapsed 6 months post-completion of therapy and was then treated with a modified dose of standard salvage chemotherapy for these patients. However, he became very sick due to a significant number of toxicities, which included multiple episodes of fever and neutropenia, hemorrhagic cystitis, and worsening ataxia. And all of this required either a dose reduction of chemotherapy or a delay in chemotherapy itself. Ultimately, he had progression of the disease, and he died about 18 months following the initial diagnosis. So I'm going to move on to a second patient who had somewhat a similar presentation, but also had an additional complication of ataxia telangiectasia, which is immune dysregulation. This is a 9-year-old male who was already diagnosed with AT at 2 years of age, and now presented to us with an increasingly, rapidly increasing cervical lymph nodes, the biopsy of which confirmed to be a lymphoma, diffuse large B-cell lymphoma, and he was stage 3 at presentation. He was able to go into remission with a modified NHL therapy. However, 4 months later, he developed the other complications which could be seen in patients with ataxia telangiectasia, that is immune dysregulation. And in this case, he had extremely elevated levels of IgM. And as you see, it's about nearly 20 times the normal. Now, not only was this high, he had symptoms secondary to that. He had progressive fatigue and increased somnolence. And the intervention that was done, I'll talk about that a little later. Let's look into the immune dysregulation in AT itself. Why do these patients have immune dysregulation, or what are the types of immune dysregulation that these patients have? Now, one of the more common ones is low immunoglobulin levels. They have low IgG, IgA, and IgE, and this is thought because of a failure of the antibody switch. So normally, in response to cytokines and infections, the IgM class of antibodies switch to IgG, IgA, or IgE. Now, in patients with AT, there is a failure of this class switch recombination which happens, and hence you don't have the optimal class switch. And this class switch actually is initiated by an enzyme called adenosine deaminase, which induces a double-strand break. And ultimately, these double-strand breaks during the recombination has to be repaired by ATM. So if you have a defective ATM, there is no recombination of these genes, of these double-strand breaks. There is no repair of these double-strand breaks, and hence you do not get a conversion from IgM to IgA or IgG or IgE. In effect, what this does is defective repair followed by decrease in the immunoglobulin levels, which will explain the recurrent infections. Occasionally, the opposite effect happens with IgM because there is no class switch. You have 10% of the patients who have elevated IgM levels, and about 1% may actually become symptomatic, just like our patient did. The therapy can be effective, but again, like the treatment with cancers, they have potential fatal adverse effects. The other immune dysfunctions or immune dysregulation that you may see in patients with AT include these patients have a very poor T cell repertoire, just analogous to an aged immune system. And also they have a suboptimal T cell response to mitogen simulation. Because of the low IgA, they have recurrent sinopulmonary infections, and they also have a decreased antibody response to vaccines. Going back to our patients, clearly he was symptomatic, he needed some treatment, and the levels were super high. So we started him on plasmapheresis, which showed a partial response, and hence needed more definitive treatment like with the use of rituximab, which is a monoclonal antibody against CD20, low-dose cytoxan, and then steroids. Again, he responded very well. The IgM levels normalized after 6 cycles of therapy. However, 6 months later, he developed gross hematuria. And this was definitely a complication of what he had, of the treatment that he had received before, because this happened due to the telangiectatic lesions in the bladder, and this gross hematuria was really kind of prolonged and distressing. It required multiple modalities, including repeated explorations of the bladder. But ultimately, he developed another complication, the pulmonary infections, and died of pulmonary hemorrhage about 2 months later. So as you see, these two cases kind of, just kind of reinstates or reinforces the fact that I said earlier that these are difficult patients to begin with because they have high aggressive tumors or immune dysregulation. And again, the treatment itself may be effective. When it's effective, it could induce long-term complications. So just to summarize, Ataxia telangiectasia is a disorder of defective DNA repair, which leads to immune dysregulation and cancer predisposition. These patients have an increased risk of high-grade chemotherapy-resistant lymphoid malignancies. Their disturbed B and T cell homeostasis leads to recurrent infections and hypogammaglobulinemia or hyper in occasional instances. Now, these patients are extremely challenging to treat. They have considerable short and long-term therapy-related side effects, and hence novel treatments are required, especially some with less side effects. And that's what you guys are going to be hearing about in the rest of the morning session. And with that, I'll end my talk, and I'll be happy to take any questions.
Santhosh, excellent job. So what is the mechanism for the things that they have, like pulmonary infections and stuff? Are they related to the pulmonary fibrosis and the pulmonary complications they have?
Well, it's again, I think most of the studies do not have large numbers of patients to kindly corroborate whatever is proposed as a theoretical mechanism, but it is shown that they could have increased incidence of pulmonary fibrosis, especially when they are exposed to drugs like busulfan. So that might be the contributing factor which causes pulmonary complications, but it's known that these patients can have pulmonary complications.
In your review or lecture studies or something, did you come across what is the actual mechanism for pulmonary? Because even people who don't have malignancies, the most common cause of death, like pulmonary failure for those patients. So do we know what is it?
I haven't looked into that. Yeah, I haven't looked into that.
Very nice talk. My question relates to the role of ATM feeding into the Fanconi pathway and the increased risk of breast cancer. So how would you monitor women older than 40? What is your suggestion for monitoring the risk for breast cancer?
Some of these patients do have increased risk of breast cancer. In fact, even the patients who are just heterozygous for these mutations definitely have an increased risk of breast cancer. But I'm not aware if there is certain guidelines that is to be employed in monitoring these patients. Cancer screening probably, in like in any other patient would be, in these patients, you probably would want to introduce a little earlier. But again, the role of cancer screening itself sometimes comes into the question, like mammography and all those things. And these patients have increased predisposition to, and they have radio sensitivity too. So I don't know where these two recommendations can actually merge. And I don't know if there are anyone or anybody who has suggested guidelines as to how to screen these patients for breast cancers separately from patients without AT. I don't know about that.
Santhosh, so the data on the small can make any comments on the transplant experience for ATs and
Sorry, no.
Any other questions? So I guess one that I have that always bothered me is, we have PARP inhibitors and all these things now that we're actually trying to allow mutations not to repair, and we think that that actually has ability to be able to treat cancer. And so it's always been funny to me. I mean, I fully understand the role of this causing cancer, but you would think that it would actually make the cancers more sensitive to a lot of the therapies that we give. And it obviously does in toxicities,
Yeah.
but it's funny to me that it really hasn't changed the outcomes of those diseases very much.
I think partly this could be explained by their aggressiveness itself, because the genetic instability, as I pointed out in one of the slides, has been shown to cause more translocations, which could explain the unusual biological aggressiveness of these tumors. I mean, as you said, clearly they are sensitive, they have radiosensitivity,
Right.
and they could, they could have toxicities. But I think the other side of the story is also that you could have more resistant translocations and imparting more resistance to any kind of therapy. So that might be the explanation for that.
All right, thank you very much.